Good evening, ladies and gentlemen. Thank you very much for this very kind invitation. I'm really grateful to the organizers. My apologies not to be present in person due to certain unavoidable situation. I'm going to focus in the next 10 minutes about PCNL complications, and will take you through some of the cases that I have collected. This is a paper published some years back by Christian Seitz, and review of over 12,000 cases of PCNL. They noted that fever in about 11% and sepsis in about 0.5% are some of the major septic issues that confront this procedure. Some of the other complications are also quite significant, but fortunately their overall incidence is quite low, with death being 0.05%, extremely low for a surgical procedure, but for a minimally invasive surgery, it's still not 0%. What I'm going to focus in the next 10 minutes are three clinical scenarios. Number one is loss of track while doing PCNL. Number two, bleeding related to this procedure. And number three, the major organ injury. And I'm going to share, colleagues, some cases that I've witnessed over the last few years. Well, it is a very common situation that while you're doing the procedure and you have started fragmenting the stone and you've cleared the major bulk, you withdraw your implant sheath to see if there is any stone left in the depth of the calyx, and you find yourself outside the collecting system, navigating the perinephric space. And since a lot of us have been doing a lot of PCNLs, we sometimes don't keep the guide wire in place, and sometimes they slip out. You're too lazy to really put them back. But this is one situation where you find that you would have been better if you had a guide wire in place. So if you are in a situation like this, sometimes you're lucky, you can get back without any further intervention. But if you have a guide wire in place, it's best to follow the guide wire. If you don't have a guide wire already in place, then it's best, before you move your implants back and look at the depth of the calyces, periphery of the calyces, place a guide wire and then do it. If you have not done either of these things, then it's becoming a little issue. If you have the guide wire, you can just follow the guide wire back into the track, but be sure not to use just the endoscopic view, but also the fluoroscopy, because sometimes the guide wire kink and you keep pushing your scope, following the guide wire, and you find the guide wire is out of the collecting system. If you don't have a guide wire and you are in the perinephric space, then the methylene blue is your savior. You can just start pushing methylene blue through the ureteric catheter, and wherever you have the highest concentration, you can just follow it using a bit of the fluoroscopy as well, and most of the time you'll be able to go back into the collecting system and see your open-ended catheter in the renal pelvis, where the methylene blue. So methylene blue is sometimes real savior in this situation, and I use it quite frequently. Let's hear another case. This is a procedure done about 4-5 months back by a colleague. 58-year-old male, recurrent bilateral kidney stone former, presented with right flank pain. His ultrasound showed there is a right renal stone about 22 millimeter in the renal pelvis, and a couple of small stones in the collecting system. in the lower pole and middle pole calyx. And there is another stone on the left side for which he was not symptomatic. It's about 17 mm. Patient was offered various options, including bilateral PCNL, one-sided RIRS, the other PCNL, or symptomatic site only PCNL. So he opted for right PCNL. Right PCNL was planned. It was slightly traumatic tract placement, implants placement and tract dilatation. There was some extravasation of contrast as well. However, the implants was placed safely into the collecting system. The rest of the procedure went on quite smoothly. Almost complete clearance was achieved, and in view of the extravasation, the surgeon also placed a guide wire. However, the patient continued to have a significant flank discomfort. His hemoglobin over the next 72 hours dropped from 13.5 grams to 8 grams. He was looking pale. He has shortness of breath, abdominal distension. At that point, a non-contrast CT was done to see what's happening, although there was a clear suspicion that he is losing blood. And as you can see that besides a small residual stone and a double J stent in place, there is a big hematoma in the perinaphric space, predominantly on the lower pole, with specks of air, all confined within the Girotas fascia. The patient was managed conservatively. Marshall's treatment was given for folic acid. Took him quite some time to recover completely, but no intervention was required. Another problem that we often face is that all of a sudden you start to see a lot of blood coming from the implants, very, very red urine, even with irrigation going. There's no visibility. A lot of things can happen at that point, but rather than panicking, one of the simplest maneuver that can be done is to put a balloon Foley catheter, inflate the balloon, and wait to see what happens. And most of the time, this maneuver suffice. You abandon the procedure, leave the Foley catheter in place as a nephrostomy tube with the balloon inflated to 3 cc. And in the next couple of days, slowly deflate the balloon to see if there is any blood coming. If the urine is clearer, the Foley catheter balloon can be removed subsequently. So this is quite a savior, this small maneuver. This is a case that I actually seen on the internet, and I'm just sharing it to elicit a point that this patient who had a partial staghorn stone was managed by PCNL through a lower pole puncture. 80% of the stone was cleared. There was an upper pole residual fragment which could not be accessed through the lower pole puncture. So the surgeon made another 20 Charrier track from the upper pole calyx, cleared the stone, and while he was removing the implant sheath, all of a sudden starts seeing a lot of yellow coming out, and this is not infective stone, it was fecal matter. So the access was made through the colon. So at this point there is no need to panic, and what you can do is to leave a nephrostomy tube drainage, as this is the lower polar nephrostomy tube, this is upper polar catheter drainage tube in the colon. A double J stent was already placed, and you can over the next couple of days slightly pull the drain tube from the colon. A cologram was also performed to elicit the anatomy. Patient is kept nothing by mouth, and TPN, peripheral nutrition of some form, is given. And most of the time you can get away with any further intervention. So in summary, ladies and gentlemen, PCNL is a highly effective surgical treatment, minimally invasive, to treat major stone burden, including staghorn stones. However, it is associated with some morbidity. But it's important that we preempt high-risk patients, put the various measures in place, recognizing problems before they happen. Majority of the perioperative complications can be managed conservatively. So thank you very much for your attention, and I hope you will enjoy a nice meeting in this beautiful city. Good evening.